Thank you all. It's an absolute privilege to be here with you and try to catch us up on time just a little bit. These are my disclosures, and in my case, they are very relevant. I am a consultant to Canfield Scientific, and in fact, a lot of the technology, including the 3D total body we're talking about, was done in collaboration with them. I'm also a co-founder of SpotDoc, which is actually a startup that's trying to provide expert skin cancer care at scale by leveraging exactly these kind of technologies. So yes, my journey with MRA goes back to the very beginning. I was actually here at the inception meeting in Washington of MRA. I've had the privilege of, and I continue to be on the scientific advisory committee, been on the grants committee, I'm on the dermatology group, and I've been funded by the MRA not once, but twice. And in fact, the technology we're talking about, 3D total body, is here in part because MRA funded this back in 2011. So I'll go through some of that with you as well. What I'm going to try to do is just re-emphasize what you just heard from Jennifer, what you heard earlier from Allison, why prevention is so important, and then give a little context of how the current House of Medicine is delivering this, but focus primarily on technologies. So, yes, an ounce of prevention is worth a pound of cure. As Allison said, there's not a patient in this group, there's not a medical oncologist who is here who would, despite all the advances we're making in advanced disease, would have preferred never to have gotten their melanoma in the first place. Obviously, that'd be the best. And if you were destined to get it, to catch it when it could be cured by simply cutting it out and not need these exciting new therapies. So what we do as epidemiologists, which I happen to have a degree in as well, is we break prevention into two things. Primary prevention, don't get it in the first place. Secondary prevention, catch it early enough so you don't have the negative consequences. Sun protection is primary prevention of melanoma. That's it, end of story. That doesn't mean every melanoma is sun-related. You can get melanoma where the sun never shines, but when the day is done, this is your only way to really prevent getting melanoma, and there are lots of resources, so I won't go into it. Early detection. That is how you prevent negative sequelae if you catch it early enough so you can cure it by cutting it out. And I've been involved in those efforts since the 1980s when people began to be aware that we needed to help the public at large and physicians get better at early detection. And I'm not gonna spend my time with you educating you about the types of melanoma, what you need to look for, how you examine yourself, but the MRA has some wonderful information about this in their Melanoma 101. Before I launch into the heart of the talk, which is about how technology is changing screening and early detection, what I do want to do is just give you a little bit of a sense of how the landscape has been changing since we started raising awareness for both primary and secondary prevention back in the 1980s. One is that healthcare itself has changed considerably. There's been consolidation of healthcare. There's been sort of what we call the roll-up of healthcare so that most dermatologists no longer have their own practices, their employees. And we've also been using non-dermatologists to increasingly provide this care, what we call advanced practice providers, nurse practitioners, and physician assistants. This is the lay of the land. This is what the framework is that this technology is being inserted to. The other thing I want to do before we launch into the specifics is to frame this in terms of, we don't think of early detection as being the same for everyone. And experts like the U.S. Preventive Services Task Force that make recommendations around screenings, who recommend colonoscopy, for example, mammography, for example, cervical cancer screening. I think it's important to understand that we as epidemiologists and they as experts think of this as two different stories. One, the population at large, at average risk, some of them at very low risk, versus those who are especially at high risk. And if many of you are here because you're patients or you're family members of patients, by definition, you fall into the higher risk category. And so I'm gonna actually think about the technologies with you from these two different perspectives. So let's start with the population at large. And I do want to point out that the experts have not recommended that the population at large formally get screened for melanoma the way that they do recommend colonoscopy, mammography, cervical cancer screening. And that's because there has never been a randomized clinical trial proving that early detection screening exams in the population at large save lives. That's partially because no one's ever done the study, and partially because it's going to be impossible to do the study for a host of reasons I will not go into. But I think it's also very important to remember that in that population at large, there are also some very low-risk populations where efforts to increase early detection might increase harms more so than benefits. We probably won't have a chance to go into that in detail. So let's think about what's gone on since the 1980s in terms of the population at large. And what happened is many of us, foundations like the MRA, Skin Cancer Foundation, American Academy of Dermatology, American Cancer Society, and a host of others that I've had the privilege of working with closely when I helped to design and co-chair the National Council for Skin Cancer Prevention. And these dozens of organizations spent the last decades raising awareness, mostly through public service announcements and written material and going out to schools and educating doctors and educating the public. And we did that. And the other thing that happened is people started to go. So now it's routine for people to show up saying, I want my skin checked. And people are now turning up with, I'm worried about this spot because of that. But the way that people are getting that information and the way that they're getting looked at has been impacted by technology. And that's because even docs don't read textbooks anymore, okay? We get our information through the internet. All of us we live on, the truth of the matter is, I just had a panic attack because I put my phone down over here. What if I had left without it, right? I leave my house without my wallet, all right, no big deal. I leave without this, panic attack, right? This is how I get my information. This is how I interact with the world. So not only do we get our information that way, okay, and by the way, how many of you do not do Google searches on a regular basis? How many of you know that you can actually search Google using the little camera pointed at anything and search visually? Well, since 2022, you can point it at a skin lesion, and it does search based on what you are looking at. Now, they tried to launch that as a diagnostic in Europe, and they pulled it back, so we won't go into that story. But that's one of the ways you can get information today. But there are also a host of apps that are there to educate you specifically about skin cancer, melanoma, prevention, early detection, even help you track your own moles. But what if you don't want to just rely on the app? What if you want somebody in the loop, but you don't want to go to the doctor? Well, teledermatology is now a multi-billion-dollar business, okay? The simple reality is this obviously got a huge boost during the pandemic because even seeing your regular dermatologist often turned into a televisit, right? But there are now apps out there that you can take a picture of something, and yes, there's AI in the pathway for many of these apps, but ultimately, the image gets put in front of a clinician, and they can give you an answer. So things are evolving very quickly. What are the challenges? Well, the beauty of it is we're democratizing access through information through the internet, even triage through an app. But what happens when you're worried about that spot? Who are you going to go see? And the reality is, across the country right now, there is a huge mismatch between supply and demand for expert dermatologic assessment. And in fact, more than half of the assessments and biopsies being done in the US right now are not by the dermatologists, they are by those advanced practice providers. And don't get me wrong, some of them are wonderful, but they never went through dermatology residency. There's no formal training in skin cancer for advanced practice providers that is required. Okay, so how do we now address this huge demand of people walking through the door? And what it's also doing is it is causing an epidemic of biopsies. And out in the community, if when in doubt, I better cut it out, translates into 60 biopsies for every melanoma that is found, that becomes quite a problem. And we'll come back to another concept, and that's called overdiagnosis. So that's the population at large. What about the high-risk population? And who makes that up? And we alluded to this before. Okay. Obviously, if you've already had a melanoma, you know how to make one, there's a chance you're going to make a second one. If someone in your family, multiple people especially made it, then there might be something either genetically or environmentally that you share with that family that puts you at increased risk. And as Jennifer already alluded to, one of the things that makes people at greater risk is having lots of moles. I actually was part of the group that described dysplastic nevi as a risk factor for melanoma, egad, back in the 1980s. And the reality is, okay, helping that population is more challenging, right? Because as opposed to finding that new tree on your front lawn, they're trying to find the changing tree in the forest, starting out with lots of atypical moles. And that's why she alluded to the technologies we're talking about. So what are the technologies that can be used in order to help the higher risk population, and especially those who already start out with atypical moles or concerning spots? So when the day is done, there are a host. But the two major technologies we're going to be talking about here are total body photography and digital dermoscopic follow-up. So Jennifer already alluded to her experience that when you have a lot of moles, okay, and especially if you have lots of atypical moles, and as we just said, this is a daunting challenge, right? And what is the goal here? Well, there are two goals. One is to find the morphologic outlier, the one that looks like melanoma in the first place. That's challenging when many of your moles have the ABCDs of melanoma, but docs are still pretty good at that, okay? But what's an even more sensitive way is to look for the changing spot. Now, by definition, if this is what you look like as an adult, okay, but you didn't have a single mole when you were born, which is true of almost all of us, every one of these spots has changed over time, right? So it's not a question of have they ever changed. But by the time you get to adulthood, and yes, people with funky looking moles, their moles keep changing farther into life, well into their 30s. Most people, their moles stabilize by their 20s. But at this juncture, if there's one spot that's changing color, shape, or size relative to the rest, well, cancer is dynamic. Something that's sitting there not doing anything, not acting in a concerning way. Something that is changing, that needs attention. So when the day is done, it wasn't really, I didn't initiate this, it was actually my mentor, Wallace Clark, and another wonderful dermatologist at NYU, Al Kopp, who really pioneered the whole idea of total body photography. And all they did was they took regular pictures, and believe it or not, when I started out, each patient had a photo album of 3x5 prints, and we would compare the pictures to the patients, okay? And then when I came to Memorial in 1997, we did the first total body digital imaging. The other thing that evolved since the 1980s is something called dermoscopy. Many of you, because you're at high risk and you've seen dermatologists, have had your doctor do this. What they're really doing is they're looking through a specialized device that takes off the glare, allows them to see things you can't see with the naked eye, and makes us better at diagnosis. And again, it works from both perspectives. Morphology, so when we look at it, we can make a diagnosis of melanoma on something we might not have been able to without dermoscopy. But the change thing also applies here. If something is changing on dermoscopy, and you can monitor for that, you have an even more sensitive way of knowing that this is concerning, but that also means you have a way to avoid unnecessary biopsies. Because if it's like, I'm not that worried, but maybe it's something, and I can do digital dermoscopy monitoring of an individual spot, now I don't have to start worrying about I have to take everything off. I can monitor certain things without a biopsy. Well, yeah, this is the younger version of me. That, in 2011, was funded by the MRA with an industry-academia partnership, yes, with Canfield Scientific, mentioned earlier before, to create total body photography in 3D. So in 1997, we started doing with some digital cameras. By the way, the first camera I bought when I got to Memorial Sloan Kettering, which was almost as good as my iPhone camera today, cost $27,000, just to put it in perspective. Okay, so why do we go to 3D total body photography? There are a couple of reasons. Part of it is it makes more sense. Part of it is because if my hand is perpendicular to your line of sight, you know exactly what the distance is from my thumb to my pinky. But if it's at an angle to your line of sight, you can't know that. And in 2D photography, by definition, on a curved surface, a lot of things are not perpendicular to the camera. 3D, everything is perpendicular to the camera. The other reason we did this was because we want to be able to track individual lesions over time. A, tag dermoscopy images to them. B, get to the point where the computer can tell us what's changed. Well, in order to do that, every spot on your body should have a unique coordinate. But if I have a mole right over here on my cheek, it's going to be on the front view, it's going to be on the side view. Doesn't really work. So what total biophotography does for us are a few things. I wanted to give you some sense, so I cheated, and I pulled a couple of snippets out of 2 interviews that I did over the course of the years, just to show you from my perspective how it evolved.
We begin with a closer look at the most common cancer, skin cancer.
1, 2, 3.
That's the $27,000 camera.
Digital photography, one of the tools doctors are using today to monitor people at high risk for developing skin cancer. But it's what could be used tomorrow that I recently tried out.
And you're going to stand it here.
The future of skin cancer screening has arrived with this odd-shaped machine.
So these are all cameras here? Yes, so a total of 92 cameras. They all shoot essentially simultaneously.
Then, within minutes, a software program builds a 3D image of the patient's body in precise detail.
So this is what the Vector 3D looks like, and that's what happens. Patient walks in, 3-millisecond capture. It creates a 3D image. We can actually zoom in. We can see anywhere in the body, get down to the level of individual spots. And now every single spot has a unique coordinate. So now if I want to do dermoscopy monitoring of that spot, I tag it to that particular spot, and I can go back to the exact same spot over time and see, is it changing dermoscopically? But now, of course, it's getting even smarter. So the computer can now find, if you look at the little number up there, all close to 300 of this patient's moles. But not only that, it can say, what do we look for? One of the things we look for is the outlier, the ugly duckling. Well, if there's one that stands out, you can just click on it. It takes you to that exact spot on the patient. But it's even better than that. What happens if now I bring the patient back and I put him back in the 3D machine? Well, now every lesion has the exact same coordinate, and it's the exact same size and shape because everything's 3. So now, in every one of these triplets, the left column is last year's image. The middle column is this year's image. The right column is the computer telling us what has changed. Blue means it's bigger or different. Yellow means it's getting a little lighter. What if we actually click on one of the blue ones? It actually gives us a whole bunch of information. By the way, it can also give us an AI diagnosis, but that's not FDA approved at the moment. And it highlights where the spot is on the patient. Now, of course, this is all computer generated, so maybe it's being fooled by something. So then it also shows us that exact spot on last year's image compared to this year's image, so we can tell, is that a real change? So that's what we're doing right now in our practice, and this is what's being done at a few major medical centers around the world. And I will not lie to you, this has been adopted more quickly in Europe and in Australia than it is in the US, which is part of the reason we're creating SpotDoc. And this is an example of the new digital dermatoscopes, which literally allow you, the patient, to potentially see what the doctor is seeing on a video screen and to monitor things over time. And yes, there are AI algorithms in these, and again, not FDA approved. And even your doctor now, in their own office, may no longer be using the regular dermatoscope that they just look through, but they actually are using a digital dermatoscope in their own practice so that they can keep pictures of things that they can monitor over time. So that's where things are evolving in terms of the technology for the high-risk patient. But one of the reasons I was asked to speak here is because obviously you can't give any talk today without thinking about artificial intelligence because it's affecting everything in our lives. And I will tell you, ChatGPT and I had quite the conversation on the train coming down here, okay? It probably would have given this talk better than I did, okay? We actually got quite a bit. I actually designed a website, okay, on ChatGPT for education of some of these things that is off the charts. So yes, all of us are aware how AI is developing. So backstory of the International Skin Imaging Collaboration. I'll tell you one little anecdote. So back in 2014, I was giving a big plenary session at a melanoma conference in Brisbane, Australia. And I was asked to do exactly what you'll be hearing from some people, the forward-looking talk. And it was obvious by then AI was going to come, digital imaging was on its way, so I gave this talk, and a few people walked over to me, and I'm glad to say they gave me some accolades, except one of my colleagues, Luc Thomas, okay, from France, walks over and goes, Allan, pretty good talk, but talk is cheap. Why don't you do it? Crap. On the plane home from Brisbane, I came up with the concept of ISIC. and because of some very close collaborators around the world. And this is the homepage. You can literally go on right now on your computer. If you put it in ISIC, I would actually put in ISIC skin because there are a bunch of other ISICs. But what we did was we created ISIC. What it is an academia industry partnership with well over 40 participants now. And the idea was very simply, how can we together try to take advantage of the digital era to improve melanoma diagnosis, in particular skin cancer in general? And we were trying to do a couple of things because frankly, dermatology, unlike other areas of medicine like radiology, has no standards for imaging. I won't bore you with that because standards are boring, but they're really important, and we've been developing those. But the other thing that we realized is we need to engage the computer science community around this, and we decided we can do this in a couple of different ways. And any of you who understand a little bit about AI understand what AI of today needs. It's voracious for data. You give it enough data, and it gets really smart. You give it the wrong data, it gets stupid. You don't give it enough data, it can't get smart enough. So the first need in our space was data, so we created a public archive that anyone can go to get images to train their AI. And then that's not enough, though. The computer science aren't going to know about it. How do we make them aware? How do we wave the data in their faces? So we started launching things called grand challenges, which they love, because they can use the data, they can compete against each other to try to come up with the best AI algorithm, not to mention the winners get a prize, and they get to publish the results. So everybody's excited by that. And lastly, we try to engage them through workshops. So again, go online. This is the ISIC archive, and what you're going to see is right now, through our efforts, there are now over 1.3 million skin images in ISIC with over 10,000 melanoma images. We've hosted a bunch of these challenges, and to give you some idea, by 2018, the algorithms coming out of the challenges were better than 430 dermatologists that we recruited from around the globe to compete against the algorithm in a quiz of 30 images each. By the way, the dermatologists were so taken by this, the average dermatologist did the quiz 5 times on 5 different set of images. So it was huge, and across the world, the algorithm beat 97% of the people. Now, I am now going to share with you that you are looking at one of the dumbest people on the planet. Okay, why? Well, who won the 2018 challenge? The company NVIDIA. Who did not buy stock in NVIDIA? Okay. So not only did NVIDIA win the challenge, they gave us their algorithm. Okay. And I'm going to come back to that in just a minute. But just to give you some idea, this year's challenge, which concluded in September, we had 13,000 entrants into this challenge. We ended up with over 3,400 final participants, teams that competed in the challenge. And we hosted it on what is considered the leading platform for doing this. And suffice it to say, the algorithms continue to get better. The 2018 algorithm that NVIDIA gave us, and we've put in the public domain, anybody can access this now. We actually did a prospective clinical trial with it at Memorial, and here is literally what the doctors got to see. If we saw a lesion that we were going to biopsy, that was concerning enough for a Memorial doctor, and we think we're pretty good at what we do. We're going to biopsy. Before we did the biopsy, we had to write down, what do we think it is, how sure we think it is, what would keep us from doing a biopsy? And then we got the information from the AI algorithm. It tells us, compared the blue dots are benign nevi, the red dots are melanomas. It tells us, where does this stand relative to all the previous nevi and melanoma that the computer has ever seen? And this is what's called a saliency map. It means, is it looking at the mole or is it looking at something else? And suffice it to say, even Memorial Sloan Kettering dermatologists made better decisions with the help of the AI. These are just some of the workshops that we've run at the leading vision science meetings. And once again, the MRA has stepped in. So just last year, the MRA gave us a Team Science Award to work with multiple partners of ours in Europe and Australia to add to all the images in the ISIC archive, not just the ultra high quality images that come out of the leading melanoma centers, but smartphone images taken by the patients themselves, because we realize AI is already being used in the front line for triage. The computers need to know the difference between different quality images and how to move forward. So when the day is done, there's no question AI is going to enter the way that we do this and has already entered the way that we do this on multiple different levels, okay? It's happening direct to consumer, okay? Again, you could do a Google search now. You can use any of those apps, many of which have AI, even though some of them should not because they're not FDA approved in the US. In Europe, by the way, Skin Vision, which is an AI-directed app, claims something like 5 million visits. We're not talking about low volume here, okay? We already mentioned advanced practice providers are delivering a disproportionate amount of the skin cancer diagnosis and care. Obviously, they can benefit from being upskilled, but we've also demonstrated at Memorial Sloan Kettering that even experts can be aided with this. There is a first AI device that has been approved by the FDA, and it is not a visual device. It doesn't take a picture. It does what's called multispectral, okay? And it's not designed for use by dermatologists, but it is designed for use by general practitioners to decide whether or not to refer a patient to a dermatologist. There are some 17 other groups out there that have AI applications to the FDA for image-based AI. We'll see where it goes. So, what have I tried to tee up for you? What are the advantages of AI? Well, it can make us better at what we do, assuming it's been trained well on the right data sets that are representative enough of the population at large. It could democratize access. All of a sudden, in your hand, you might have something today that's as good as a dermatologist, okay? That's pretty impressive. But, as Jennifer pointed out, I don't want to just pull the wool over their eyes and say, this has been solved. It's not solved, okay? There are also some real challenges. One is, those data sets are not yet good enough. They don't represent all skin types. They don't represent every possible kind of a lesion. And like people, computers can't know what they don't know. So they're going to try to pigeonhole everything into things that they do know, okay? And that can be challenging. The other one is, I've mentioned the FDA multiple times. In order to get this out for being used, it needs regulatory approval, and it's really tough for the FDA to know exactly what to do with a device that's getting smarter on its own. How do I monitor it? How do I know it's going to happen? And how do we ensure quality control once these things are out in the wild? What if the iPhone 17 screws up the algorithm because it's a different kind of camera? It's doing different stuff. Who's going to pay attention to that? How are you going to know that? So the other problem is I've alluded to earlier, and that is there's this problem called overdiagnosis that I'm not going to go into great detail in, but the short answer is every form of screening, whether it's colon cancer or breast cancer, cervical cancer, or a melanoma, comes at a cost. And that is, the harder you try to find early disease, the more likely you are to A, do a lot of unnecessary biopsies. That's one harm. 2, cause a lot of anxiety along the whole path of getting checked out, etc. But then there's this thing called overdiagnosis, which is a fancy way of saying, they tell me I've got prostate cancer, they're right, okay? But the reality is, I'm going to die of something else long before my prostate cancer becomes a problem. Well, if you do that, what's going to happen is all the treatment I get for my prostate cancer is pure harm because it wasn't going to spread in my natural lifetime. And we know that more than 50% of guys who die in their 80s have cancer in their prostates. So if you look hard enough, you're going to find it in all these 80-year-old guys. Is that a good idea? No, that's why we don't suggest screening starting at those ages. It's also true for melanoma. The harder you look, the more you're going to find things that someone's going to call melanoma that's actually not going to go on to hurt them in their natural lifetime. That's harm, and we have to be careful about that. It turns out, if you start applying a lot of detection pressure in populations that are very unlikely to die of melanoma, the risk of harm outweighs the risk of benefit. So we need to be very careful that the algorithms are risk-based. that they don't start with the assumption that everybody gets melanoma at the same rate, because if they do, it's going to be very, very misleading. Okay. The other reality, though, is the more we increase diagnostic pressure, that supply and demand problem for actual dermatologic care and biopsies gets worse. So we need to, at the same time, be addressing how do we give access to high-quality, patient-centric care, not care that says, you're worried, I'll do a biopsy, and everybody gets a biopsy, and we turn everybody into Swiss cheese. That's not the answer. By the way, I said that to a Swiss colleague recently. He said, Allan, we think very highly of Swiss cheese. So you got to be careful. But the bottom line is, as we do this, we have to have real thought processes in how this gets implemented in clinical practice. So what I've tried to do is catch us up on some time, so I apologize for talking like a New Yorker at 400 words a minute, but I could tell some of you kept up with me. And what I tried to cover with you was very simply, yes, you're going to be hearing about tons of exciting things over the course of this retreat, and yes, what's going on in advanced disease is wonderful. I've got to tell you, as Allison knows, those of us, you know, I had the privilege of co-directing the melanoma program at MSK for many years, and the day that we had to open up a melanoma survivorship clinic, holy crap, what an amazing event. But when the day is done, every one of us in this room rather not be seeing those medications, we rather be avoiding melanoma in the first place. I have faith this is a pretty good sun protective group. Catching things early, yeah, my guess is you guys are already doing the right things, but how do we make that available to the public at large and avoid other people from dying of melanoma? And I've tried to give you some idea of how changes both in the healthcare system and especially in technology are impacting that, and hopefully gave you back at least 10 minutes of your lives. Thank you very, very much. It's been a pleasure chatting with you.
Any questions out there? All right, on my way, Elizabeth.
Thanks a lot for the talk. It was very informative. Can you explain where you're getting all those images and how that permission works, or how are those collected?
I was afraid someone was going to ask that. No, it's a great question. It's actually a wonderful question. And that is why almost all of these images are coming from major melanoma centers, and they're not all consented specifically. The IRBs have agreed at those centers that individual lesion images without any identifying information about who they came from are considered anonymized, okay? They're really not anonymized, they are, quote, de-identified, okay? And so that's the way that we were able to get permission to do that, but in order to get the computer smart enough, ultimately we also need to give them overview pictures, right? And so the other mechanism is on consented IRB approvals where patients are agreeing to let us use their pictures. We have not put anyone's total body naked pictures on the internet. For the most recent challenge though, what we did do is we actually have algorithms that pulled out all the individual lesions off of a given patient, okay? We made sure that they're not representative enough so that someone could identify that patient, but the computer knew multiple images were coming from the same person, because we also want the computer to get smart enough to know how to find on a given patient which spot. That was me trying to remind myself to give you guys time back. So yes, so that's the other thing that we are doing as well. For the smartphone process that we're talking about that the MRA is funding, those patients are going to be taking their own images, again, only individual lesion images, and they are consented. Okay. Yeah. Any other questions? Oh.
Hello. How are you doing?
Blinded.
I'm over here. Quick question. You mentioned in terms of imaging and some of the technology and hardware, in other forms of artificial intelligence or machine learning, are there companies or organizations or institutes that have taken a specific interest in this, and whether it's large language models or ones that go through database to make sure that the initial diagnosis were correct? Because I'm in an ICRO pool, so sometimes people aren't properly diagnosed. It goes into archives, and then later they have to go back through thousands of records to then make sure the diagnoses were correct. Who is doing this work? I know you mentioned the group you work with on the imaging side, but in some of the other arenas, who does this work? Who cares about it? How can I learn more?
Great questions. And so, boy, the short answer is there's a lot of interest on it from every level. Google, when I started this, one of my core members of my group was actually given to us on loan by IBM. It turns out that multiple CEOs of IBM have been on the MSK board. MSK leveraged that. IBM gave me one of their experts. That individual is now running foundation models at Microsoft, okay? And Google, the lead developer of the Google Lens skin application is actually a member of ISIC and has helped coordinate some of our workshops. So there are people working at this from the level of the giants down to cottage industry, down to individual researchers at many different universities. So which is why we have over 3,000 participants in our challenges, and they span all of the above. But when the day is done, your earlier point is really fascinating, okay? And that is where we're going with this is it's one thing to get an answer from the AI. It's another thing to know whether or not you can trust it. And I showed you what we call saliency models, where you saw the yellow and the algorithm was focusing on the same place that you were focusing. Maybe that means something. For those in the AI world, they know that saliency maps is not the right way to know whether or not the AI is trustable. But imagine if the AI could talk to you and say, the reason I think this is a melanoma is because A, B, and C. That's actually where our current research is going. So in terms of someone like you becoming more informed, the short answer is you can actually just start looking at some of the ISIC publications. But yes, things are rapidly changing. Any other questions? Thank you.